Hi friends, uh, let us continue with this. A few drugs for this treatment of Cushing syndrome, right? So now let us understand few important points under this Etomidate. You know that the Etomidate is anesthetic agent, right? It is an high anesthetic agent. So what is the function of this? How the mechanism of action? What is the mechanism of action of this Etomidate? Etomidate, when we give the Etomidate, it goes to the CNS, right, where it acts on GABA. So it depresses the CNS functions actually, right? It depresses the CNS functions. So let us understand this Etomidate is used in uh, cardiac surgery, right? It is used in cardiac surgery and it is used in vascular surgery. So you have to understand that the Etomidate, this is an anesthetic agent. This is used in cardiac surgery and in the vascular surgery because it all depends on the intracranial pressure actually, right? So whether it increase or depends, so that is the reason. Based on that, we're gonna see whether we can use in the CNS. But right now, this can be used for the cardiac surgery here and the vascular surgery like aneurysms. And we got few side effects when we use this Etomidate, and the side effects are, you can see this adrenal cortical suppression here, right? You can see this adrenal cortical suppression, and it also leads to vitamin C deficiency. Vitamin C deficiency. So if you date a girl, you have to be very careful. You have to look at the coin. C for coin, C for coin in the sense money, C for vitamin C, and other C is for the cortical suppression. So this is how we can just remember the side effects of Etomidate. So what does this nitrous oxide does? If you look at this nitrous oxide, right, and this nitrous oxide causes a vitamin B12 deficiency, right? So you can see this night you are watching B, right? You are watching B. So vitamin B at 12 o'clock, vitamin B12 a deficiency. It causes vitamin B12 deficiency that can lead to megaloblastic anemia. So these are the important points you have to understand regarding the nitrous oxide which causes vitamin B12, right? And this Etomidate which causes vitamin C deficiency, right? So I have already told you the Etomidate acts on the GABA receptors and there is influx of chloride ions and it leads to depression, right? So these are the important points you have to understand. So let us understand the other important points here. The other important points here is you got something known as melothane and amino glutamide, right? Amino glutamide. So if you look at this melothane, right? So how does what is it? What are these? This melothane and amino glutamide. These are chemical adrenalectomy. So they have got that suppressions. If you see the example of melothane, the mechanism of action, where it modifies the peripheral metabolism of steroids and directly suppress the adrenal cortex. If you look at this, it directly suppresses the adrenal cortex here, right? It modifies the peripheral metabolisms of steroids and directly suppress the adrenal cortex, right? It directly suppresses the adrenal cortex. So these are the important points you have to understand how this melothane acts. So just understand that it modifies the peripheral metabolism of steroids, right? And it ultimately suppress the adrenal cortex. So that is the reason this is a chemical adrenalectomy, because it is suppressing the adrenal cortex where you have got a lots of corticosteroids secreted here, right? So now let us understand the next drug, the important drug. If you look at this is something known as ketoconazole. So ketoconazole is antifungal, right? Antifungal. It is an antifungal. Fine, in men it causes gynecomastia, right? It is anti-androgenic action. So you should understand the basic concept here. The thing you have to understand here is, if you look at this is what the squalene, lanssterol, ergosterol, and the cholesterol. For the conversion of lanssterol to ergosterol, you got some enzyme known as 14 alpha demethylase. So what does this ketoconazole does is they go and inhibit this enzyme, so there is no formation of this ergosterol and there is no formation of this cholesterol, cholesterol. So that is how this ketoconazole that acts, right? So in men, if you look at the in men, it causes a gynecomastia, right? In men it causes gynecomastia. It has got this anti-androgenic action. So you should understand how it has anti-androgenic action. So if you look at this, now there is no formation of ergosterol, there is no formation of cholesterol. Normally the cholesterol is converted into progesterone, then 17 alpha OH progesterone, then androstenedione testosterone dihydroxytestosterone. So now there is no formation of cholesterol, there is no formation of androgens here, so no formation of testosterone in this aspect. So this is what the anti-androgenic action, because of the blocking of this enzyme there is no formation of these androgens. So that can lead to gynecomastia in the males, right? So you have got another drug. We already spoke about the rapone. It is methyl rapone. It is used in Cushing syndrome, right? So these are the important points you have to understand regarding this. So let us understand the next one. The next thing here is you got something known as phentolamine. You know that it is an alpha blockers, right? We already discussed about that, right, regarding these alpha blockers. So now let us understand how this phentolamine, which is a non-selective, right, a reversible, right, it is a non-selective alpha blockers, a reversible. So if you look at this phentolamine, the drug of choice for clonidine withdrawal hypertension. So one thing you have to understand here is this is what the adrenergic nerve, and you have got an alpha 2 receptors here. This is what the muscle is. So whenever the clonidine acts on the alpha 2 receptors, that can suppress the synthesis of this norepinephrine here. So that is how the clonidine acts. So what happens when you withdraw the clonidine? So there will be like heavy rush of formation of the, which was stored here, the stored content of these points here. There is a rush or the formation of heavy norepinephrine, and it releases out and it acts on the receptors here, right? So these are the important points you have to understand, that whenever you withdraw the clonidine, that can release the norepinephrine. So that can release the norepinephrine, that can act on the receptors. When it acts on the receptors, so say example, if it acts on the alpha 1, right, if it acts on the alpha 1, it leads to hypertension, right, because of constriction or the constriction of the smooth vessels can lead to increased blood pressure. So what are we going to do is phentolamine, it blocks the alpha 1 receptors also, so it can decrease the blood pressure. So that is how we can, this is a drug of choice for clonidine withdrawal hypertension. And the next thing you have to understand is treatment of hypertension due to cheese reaction. So what does it mean here? If you look at this is what the cheese reaction is. If you look at the cheese reaction, in the cheese reaction, if you look at when you start taking cheese, beer, red wine, banana, they all contain thymine. So they all contain thymine here. So in presence of MAO inhibitors, say example, if this is the presynaptic nerve, this is the muscle here, and you have got a MAO inhibitors which inhibit the enzyme MAO here, right? So that there is no breakdown of the points here. So what does it do here is, in presence of MAO inhibitors, the thymine it escapes degradation. So there will be no degradation of thymine in presence of MAO inhibitors. So the thymine which we take here, they all ultimately enters into the nerve, and there is a formation of norepinephrine. So once there is a formation of norepinephrine, it goes into the vesicle and it is released. It acts on the alpha 1 receptors, and there is increase in BP. That is what the hypertensive crisis is. If in such conditions, when there is increase in BP, also increase in hypertension, so we can give this phentolamine. And the next thing you have to understand is pheochromocytoma. Surgery with hypertension, I have already told you, they start release this catecholamine, they act on this, they release this adrenaline, they act on the receptors that increase the hypertension. To decrease that, we can use this phentolamine. And the next thing you have to understand, there is something known as oxymes, right? The oxym, pralidoxym, all those, they oxymes induced hypertension also. We're gonna use this phentolamine since it is an alpha 1 blocker, right? So let us understand the next thing here. The next one you have to understand here is can be injected into this phentolamine can be injected into penis. So the one thing you have to understand here is, you know that the alpha 1A or alpha 1, so it is also present in these in the blood vessels, right? So whenever you give this phentolamine, right, that blocks this alpha 1 receptors, so there is vasodilation. So when there is vasodilation, there is entering of blood, and you can see this, there is erection of penis. So we can use this in the erection dysfunction, right? So these are the important points you have to understand. And in the erection dysfunction, we can also use the other injectable therapy for erectile dysfunction. Is we have got something known as pipe therapy. Pipe therapy, it is pharmacological induced penile erection. It is a pharmacological induced penile erection. So you can look at this is a pharmacological induced penile erection. In this point, you can see this, we got a drugs here. The drugs here is alprostadil, and you have got phentolamine, you have got papaverine. So if you look at this alprostadil, right? So let us understand what is this alprostadil. It is an prostaglandin E1 analog. So let us see how that helps in the erection here. If you look at this prostaglandin E1 analog, right? Prostaglandin E1 analog here. In this point, if you look at this, and this, whenever you give this alprostadil, which is a PGE1 analog, it is an intracellular secondary messenger. So whenever we give that, there is increase in cyclic AMP in these epithelial cells. So you can see this, that they can be because of neural, but right now we are studying about this PGE1. Whenever we give, there is increased cyclic AMP. That's increased cyclic AMP in turn activates this kinase and ionic channel. So you can see this, whenever these channels are activated, there is decrease of calcium in the cells, right, in the muscle or in the endothelial cells. So that leads to decreased calcium, leads to smooth muscle relaxation. When there is smooth muscle relaxation, you can see the blood enters, there is erection. So these are the important points, that alprostadil is, it is a PGE1 analog used for erection here. And you have got phentolamine, already I have discussed that, where it blocks this alpha receptor vasodilation. And the next thing you have to understand, there is something known as papaverine. So this papaverine is a non-selective phosphodiesterase inhibitors. So if you look at this, you got something known as in this nerve cell or endothelium, you can see this nitrous oxide. This is then muscle, this is endothelial cells. This nitrous oxide, it activates the guanyl cyclase, so GTP is converted into DGMP, right? The GDMP, if you look at this, so ultimately if you look at this, at the end there is decreased calcium and relaxation, there is blood enters, and there is erection. But you have got something known as PGE prostaglandin, right? You can see this is a prostaglandin E, right? In this prostaglandin E, so what does it do? This phosphodiesterase E, this is an enzyme here where it converts the DGMP to GTP. So it decreases the action of relaxation. So we're gonna block this. This is what the phosphodiesterase E, right, PDE5 inhibitor is gonna give some inhibitors like papaverine. So we're gonna inhibit that, so that now there is a much increase in DGMP, so ultimately decrease calcium, and you can see erection. So these are the important points you have to understand at this aspect. So now let us understand regarding these beta blockers, right? So let us understand these beta blockers here, right? If you look at these beta blockers, the first thing you have to understand here is, we have already read with the alpha blockers, alpha 1, alpha 2. Same in the case right now, we have got the beta blockers. In the beta blockers, we have got beta 1, beta 2, and beta 3, right? If you look carefully here, now let us see the location of beta blockers here, where they are present. If you see the beta 1, they are present in myocardium, and they are present in kidney here, right? If you look at the action of beta blockers, whenever I activate the beta blocker, right, whenever I activate the beta receptors, so since the beta receptors are present in the myocardium, whenever I activate, it increases the heart rate, that chromatography, it increases the force of contraction, that is inotropic, and increases cardiac output, right? Because whenever we stimulate the beta 1 receptor, say example, if this is the heart, you got the receptors, this is what the beta 1 receptor present on the heart. Whenever I stimulate, it has got all the positive effects, right? If you look at the kidney, even the kidney has got the beta 1 receptors. Whenever I activate this, it increases the renin, so there is renin release, right? So we have got some selective beta 1 agonist. The selective beta 1 agonist is dobutamine. So you have to do the things here. So since you have to do the things, this is what the synthetic catecholamine, this is synthetic catecholamine, that is dobutamine, right? So the next thing you have to understand here is, this is what you have to remember, dobutamine is selective beta 1 agonist, right? And if you look at this exogenous or synthetic, right, synthetic catecholamines are exogenous or synthetic catecholamines are, you have got something known as isoprenaline also, right? Isoprenaline. So let us see this isoprenaline, dopixamine, dobutamine, and phenoldopan, they act on the different receptors here. Say example, if you see this isoprenaline, right, I saw her three times, 1 2 3. It acts on beta 1, beta 2, beta 3, isoprenaline, right? And you can see dopeaxamine, right? If you look at this, if you start taking this dope, right, so you can see dopamine, it is dopeaxamine, it is D1 and beta 2, D1 and beta 2. This is what you have to understand, that this is starting with the D, so it is D1, you can just remember like that. So it is dope or dope, this is beta 2. If you look at this, this is what the dobutamine. If you look at this is the but, so you can see one but, so beta 1. But if you see the TF of this but, dobutamine, it is 2 minutes, right? And if you look at this, they may ask you which chemical is used in stress echo or stress ECG, and it is dobutamine. It is used, the half-life is 2 minutes. This is used for the stress echo and stress. So this is how you can just remember. I saw her 3 times, beta 1, beta 2, beta 3, and this is dope. So it beta 1, beta 2 here, and the but single beta 1. So next we have got something known as phenoldopan. So phenoldopan, if you look at the phenoldopan, if you observe all these 4 here, you don't have any D in the center, right? So you can look at this. This is dopam D for D1, right? It acts on the D1 receptors, If you look at this, the D1 receptors are present on renal blood vessels. So whenever I activate whenever I give phenoldopan, it activates the D1 receptors, so that can lead to renal vasodilation. So it prevents kidney failure. So I can use this in the hypertensive emergencies with renal impairment, because there is vasodilation whenever I give this phenoldopan, right? So it is IV infusion, it is given by IV infusion. So these are the important points you have to understand regarding the drugs like isoprenaline, dopeaxamine, and dobutamine, phenoldopan, all this. So let us end the session by speaking about one point here, that is beta 2 mainly present in, right? If you look at the beta 2, it is present in smooth muscles. So whenever I activate these beta 2 receptors, so if you look at this, this is what the beta 2, and if I draw like this, it looks like butterfly in the dilatation. So vascular, you can see vasodilatation, and you can see that these are mainly smooth muscles, that is vascular smooth muscles, can be vascular smooth muscles, and it can be visceral smooth muscle also. Whenever we activate this, that leads to vasodilatation. In the next session, we'll be continuing about the other topics. Thank you.